Dear viewers, Assalamu alaikum. Today we will be teaching you calcium channel blockers. You know the importance of calcium channel blockers, that they are used in certain clinical condition. But before knowing the pharmacological action of calcium channel blockers, let me share with you some key characteristics of cardiac myocytes. I have drawn here a diagrammatic representation of a heart model. Remember, the inside is representing the intracellular system and the extracellular is represented here at this model. Now you know that the extracellularly sodium ion exists, whereas intracellularly the potassium ion exists in abundance. There are chloride and potassium ion outside as well, and we have discussed in detail regarding the cell environment in our previous video that was related to the depolarization, hyperpolarization and repolarization. You can go and see that on the YouTube channel. Now let me share with you that there are M2 receptors present at the level of heart, being regulated by the parasympathetic division of the autonomic nervous system, whereas there are beta 1 receptor of the sympathetic division of the autonomic nervous system, and you are quite familiar with that, and the events happening at the level of adrenergic nerve ending are discussed in details in our previous videos available on YouTube. Now what happens? So when this acetylcholine comes and attached with M2 receptors, so it has two functions. One is it's about the ligand inhibitory protein G, inhibitory protein, and the second is about potassium. So potassium is effluxed out. Once the potassium is effluxed out, it is going to hyperpolarize this particular tissue, and hyperpolarization of this particular tissue mean that the resting membrane potential is now shifted towards much more negatively charged, that is minus 90 millivolt, because of the efflux of potassium in this case. And the efflux of potassium being the positive ion is removed, so the interior become much more negatively charged. And once it's negatively charged, thus the resting membrane potential goes from minus 70 to minus 90 millivolt, and thus a strong stimulus is now required to reach this threshold. This is the threshold, you see, that's minus 55 millivolt, whereas this is the resting membrane potential minus 70 millivolt. Now due to the efflux of potassium, it is going to hyperpolarize this particular tissue. Then a strong stimulus is required from minus 90 to reach this, so thus it's stabilizing the heart tissues. And the other aspect is that stimulating the ligand inhibitory protein is going to have an inhibitory action on the adenylyl cyclase system. Thus it is going to have a regulatory mechanism on the adenylyl cyclase system or the sympathetic division of the autonomic nervous system. Now what happens when norepinephrine comes and attach with beta 1 receptors? You know that it is going to stimulate the adenylyl cyclase system, and in stimulating this adenylyl cyclase enzyme will lead to increasing the conversion of ATP into cyclic AMP. In this will lead to cascade of events. The sodium is getting inside, and sodium getting inside, now the interior is there is a transfer of this electrolyte from the external to the internal environment. It will carry currents. Thus changes are now sensed by the voltage gated calcium channels, and now it's going to activate. So thus it leads to an influx of calcium, subsequently phosphorylation of the protein of the myofibril, and consequently it leads to depolarization with an action potential generation, which is then reflected by an action potential in myocardium, you see. Now there are certain points that we can regulate regarding this. You see, this depolarization action potential will lead to increasing the myocardium, and increasing myocardium will lead to a cardiotonic effect, and will lead to ejection of more blood into the aorta, thus increasing the stroke volume. And increasing the stroke volume, you know that blood pressure is equal to peripheral resistance multiplied by heart rate into stroke volume. Increasing the stroke volume, cardiac will increase the cardiac output, and increasing the cardiac output will increase the blood pressure now. So thus a positive inotropic effect is in the absence of calcium channel blockers. Now there can be different clinical conditions where the heart may be working with a more rate, higher rate, or the heart may be where the preload and afterload on the heart that may be increased. There may be different clinical condition. Now you see here is SA nodes, there is AV node, this is the bundle of His, and this is the Purkinje's fiber system and the conductive tissue of heart as well. Interestingly, the calcium channel blockers are going to affect these myocardial contractility phenomena, the AV nodal conduction, and the SA nodal automaticity phenomena. We will discuss that in the next slide. But now what happens once a calcium channel blocker is added? Adding the calcium channel blocker is going to block this calcium channel. This will lead to a decrease in the cytosolic calcium level. Decreasing the cytosolic calcium level will lead to a negative inotropic effect and a negative chronotropic effect because of having slowing down this conduction, AV nodal conduction. Thus, on two parameters now, the blood pressure is regulated, heart rate is decreased, of course, the stroke volume is decreased, and the next slide you will come to know how the calcium channel blockers are going to affect the peripheral resistance as well. But if we rearrange this mathematical expression formula, so it means that blood pressure is directly proportional to either heart rate or stroke volume, keeping the peripheral resistance constant, or blood pressure is directly proportional to the heart rate, keeping the stroke volume and the peripheral resistance as constant, or other way, blood pressure is directly proportional to peripheral resistance, keeping the stroke volume and the heart rate constant. This criteria, three different clinical conditions, these are applied on three different clinical conditions. For example, you have a patient with the increase in blood pressure, hypertension, with increase in heart rate. Now you want to regulate the heart rate, you want to decrease the blood pressure. So you can decrease the blood pressure either by producing vasodilator phenomena or decreasing the heart rate. So it's up to you which parameter you are going to keep constant and which parameter you are going to want to shuffle or alter or change. Now let me see. Here this slide describes the comparison of calcium channel blockers where so far its efficacy is concerned. These are the key characteristics or parameters. Dilation of the blood vessels. The second key characteristic is suppression of cardiac contractility and suppression of automaticity of SA node and suppression of the AV nodal conduction. Now verapamil, diltiazem, these are the two drugs that have a vasodilatory effect as well as suppression of SA nodal conduction with a higher rate. Now suppression of the SA nodal conduction comparatively higher rate than nicardipine, nifedipine, nimodipine, you see. So what will happen? The automaticity is decreased, meaning that the firing of the heart action potential is decreased, and this will consequently decrease the heart rate. So thus diltiazem and verapamil can be very helpful in the management of hypertension and in the management of tachyarrhythmia, because it is the SA nodal automaticity that's going to fire and induce an action potential. Now, second is the suppression of cardiac contractility, and the myocardium contraction is very significantly affected by this verapamil, whereas diltiazem is going to decrease, is not as much affecting as verapamil is going to suppress the myocardium contractility. Now, diltiazem is going to suppress the cardiac contractility, where nicardipine is not going to suppress the myocardial contractility. Now, this drug, nicardipine, which the name represents, name means no activity, like ne suffix prefix stands for no effect on the heart, usually, or minimal effect. So, and diltiazem mean del. In Urdu or Hindi, del mean heart, and V is for ventricle. It is the ventricle that is responsible for the 80% of ejection blood into the aorta. Thus, V is using the metaphor. It is very potent, plus its effects on the ventricle is very predominant because of the suppression of the cardiac contractility, and thus diltiazem and verapamil will not only suppress the cardiac contractility, the SA nodal automaticity, and the AV nodal conduction, but will also have a vasodilatory effect, whereas nicardipine, nifedipine, nimodipine will have predominantly vasodilatory effect with the low suppression, minimal or very low effect on the automaticity of SA node as well as the contractility of cardiac myocytes. But look at here, the AV nodal conduction is not affected. So thus In nutshell, this table describes the comparison of efficacy of these calcium channel blocker so far different sites of actions are concerned. Now, how it can be used for the clinical purposes? You may have a patient with the angina, with the increase in the heart rate. You see, so exertional angina or increasing the heart rate, this verapamil and diltiazem will be effective along with hypertension. And here, since it is having only vasodilatory phenomena very predominant, so they are very effective in the management of essential hypertension, and provided there is no other concomitant ailments. So this key characteristics now constitutes the therapeutic uses of the calcium channel blocker. So they are anti-anginals because they increase the coronary blood flow as well as decrease the heart rate, especially reserved for those patients who are intolerant to beta blocker. They are calcium channel blocker are antiarrhythmic, antihypertensive, vasodilators. Especially they can be helpful in Raynaud's phenomena as well, and the primary hypertension associated with asthma because of probably with that vasodilatory phenomena, paroxysmal supraventricular tachycardia, atrial flutter and fibrillation. And since blood pressure is equal to peripheral resistance multiplied by heart rate into stroke volume, so these are the key characteristics which we discussed in the previous slide. So it's up to you that which type of your patient you are going to examine and what are her clinical conditions. You may have a patient with an ectopic beat, with the increase in heart rate, with the hypertension, so verapamil and diltiazem will be a suitable drugs. But if you receive a patient simply with an essential hypertension, whether that is isolated systolic or diastolic blood pressure, so calcium channel blockers can be helpful in as they have a vasodilatory phenomena, and that will decrease. So far adverse effects are concerned, since they are going to have a vasodilatory phenomena on the blood vessel as well. So therefore, dilating the blood vessel at the level of the central nervous system may be associated with headache. Smooth muscle is affected, so the peristalsis will be affected, thus constipation may be there, orthostatic hypotension because of the vascular blood won't be able to maintain the tone, thus your patient may come across with orthostatic hypotension. Plus pedal edema. Pedal edema is important, and even this edema is sometimes resistant to diuretics as well. There may be atrioventricular block in higher doses or unadjusted doses, so you should be quite vigilant while using diltiazem and verapamil, especially in patients having a congenitally prolonged QT interval and hypotension, as well as congestive heart failure. It may precipitate because it's going to affect the myocardium as well. Now, in nutshell, calcium channel blockers are very important in managing different clinical conditions. Thank you.